practices. This year we have not. So we have received some indication of additional funding being freed up from elsewhere to support capacity in primary care, but so far the funding hasn't been at the level that we received last year. But we are working with the practices to plan for the use of the funding that is being made available. We also this year, if I could just click on one slide, thank you. We also this year have signalled our intention to pilot an urgent care service. The intention is that this will run for 18 months from October, perhaps just slipping a little bit on this timescale. And I've set out some of the elements of our commissioning intentions for the service on this slide. The procurement process for this service is still live, so I can't give a lot more information today, but hopefully this slide has set out for people what our intentions are with regard to piloting this sort of provision. And then finally, sorry, just the last slide that I've got. So these are our current focus areas. You'll see there's quite a lot of carry forward from the previous actions that I outlined, which were part of the original access improvement plan that we developed last year, as I described. There are some areas that have carried on, also some new areas, a greater focus, as I've said, on using connected care data and other intelligence with practices to proactively plan capacity. A particular focus on the registration of young males with GP practices. For that work, we've now got a digital literacy programme up and running, which is obviously really important in terms of some of the varied ways of accessing primary care and making sure that all people who want to are able to use those. And then finally, continuing to follow up, work with practices. We're having discussions with Healthwatch Reading, again, with regards to how they might be able to support us in further patient feedback work, etc. So again, really a kind of many-pronged approach. This is a really important issue for us, and we're really keen to work with our practices as far as we're able to do so to make sure that we maximise access and maintain resilience over the winter period. Okay, thank you.
Thank you very much for your part there, Helen. Just a quick couple of questions from me. Do you think some of the dissatisfaction that you mentioned is linked to people's sort of expectations around face-to-face appointments?
I think potentially. I mean, we do expect that practices offer face-to-face where clinically appropriate and where possible accommodate preferences around that. But there has been a change in working patterns, as we've outlined. So that may be the case. I think sometimes also changes in ways of working may also be reflected in the results. But we need to really keep a close eye on the feedback that we're receiving and work with practices to sort of, absorb and act upon that as appropriate.
Yeah, okay. Yeah, thank you. And just what are the contingency plans for winter, if any, in regards to appointments?
So I think, as I say, we're working closely with practices to understand where they're at and particular pressures. We have SITREP reporting in place with our practices on at least a weekly basis for all practices, and more frequently where required. So we're alerted where there are particular issues. The UCC approach that I described potentially will give some resilience for primary care, in that we will have or are intending to have a level of overflow capacity within that. Things like the advanced telephony do lend themselves to practices working with others in their PCNs where appropriate to manage demand. So there's quite a range of things in place, I would say, but it's really that kind of active management of pinch points and any particular sort of high levels of staff sickness or pressures being faced by individual practices, and working to support those.
Thank you.
Yeah, thank you, Helen. The data on some of the satisfaction, that's from the GP survey that goes out nationally I believe, was that from early in the year, sort of from the first few months of the year, and then
Correct.
it gets reported later in the year, is that right?
Yeah, that's right. It's January to March, I believe, the data collection, and it was reported in July.
Yeah. Was there any thought about from the people sort of interpreting it, the fact that we were just coming out of a huge COVID surge over the Christmas New Year period? There's a certain element of staff illness in primary care suffering from that, and also high demand at that sort of pressured time, which may have affected some of the satisfaction on telephone responses. Just from my own experience, we only started relaxing social distancing in the surgery in April because we were trying to protect our vulnerable patients at the time of a high peak of COVID. So that's when we started to switch to doing more face-to-face, and as the trend shows, it's going up and up and up, and almost reaching pre-pandemic levels now. So in addition to which, we're now doing also more telephone and online consulting on top of the face-to-faces. So that just shows the measure of the pressure in general practice, which this is a snapshot going back in time, but what's going on currently is obviously slightly different. Thank you.
Yes, Andy, I think that's right. I mean, I think with all of this, we can't interpret the data, the data sets in isolation, and we need to understand the broader context. I think the fact that it's a national trend also reflects what you're describing, that at the time of the collection, clearly there were particular pressures on general practice and a need to work as required to really keep the service going, as you say, with social distancing and perhaps less face-to-face than is the case now. So yes, I absolutely think in interpreting all of the, I mean, the data for primary care is challenging in terms of what's available, what we get at what level. It's improving, and the information that we're building locally is going to really help that. But it is really important that we see this information in context, and certainly the discussion that we have when we follow up with practices is to understand, you know, what was happening at that time, how they managed it, how they're working now. But very often, you know, the data isn't news to us when we see it. It often reflects what we already know from our ongoing discussion with those practices.
Yeah, thank you. Thanks, Chair. Yeah, so I mean, the around the satisfaction and obviously the getting through on the phone. I mean, I think, well, we always know there's variation, and you'd expect there's, you know, variation across different practices. So really pleased, and I suppose kind of hope it's successful in terms of this idea of you know, the best practice being shared. I think that's really important. So hopefully that really works. So my question is, and you might not have the answer to this, but you talked about, we're just looking at GP coverage per, you know, head count, full-time equivalent. You know, those figures are really interesting. The Reading ones aren't as good, and I just wondered whether, even, and I think we'd know that anyway, and I think that's obviously a concern to us in terms of coverage. But is it? This is just a sense. Do we have any data around then the coverage within the primary care networks of within Reading? Because, you know, is the inverse care law, isn't it? It feels that exists in Reading. It feels like there's sparser coverage in the more deprived areas and perhaps where the greatest need is. And, you know, people sometimes have to travel to the nicer areas just to go to their GP. So I wonder if, I know the whole situation is quite difficult in terms of practices being, you know, independent businesses and you know, and how to manage all that. But is that do we have data around that? Is that an issue, and is there any ways of dealing with that?
Yes, so we can extract the data in that way, the raw data, absolutely, to understand the staffing positions by PCN, and we do that for the additional roles, the ARRS staff. You know, that's all planned on a PCN basis as well, and a lot of those staff work across multiple practices within PCNs. So we're sort of increasingly looking at it in that way. I just think with all of this, we have to understand the context, not look at the data in isolation, just because the service models and the delivery models differ so much from practice to practice. The skill mix, and even where you've got similar skill mix, the way that particular staff groups are used, it does vary depending on you know, the clinical model and what's been decided with regard to how things are run. So I think that sort of analysis is helpful, and we absolutely can share that. But yeah, it's just a word of caution. I think that it's about a dialogue with the PCNs rather than looking at the data in isolation.
Any other questions? Did we have an online question? I think there's somebody. We saw a hand pop up. Alice, you have a question?
Hello, good afternoon,
Hello there.
everyone.
Hi.
Can you hear me? I'm
Yes, we can
bouncing.
hear you. Yeah.
I'm Alice Clifton. I'm the lead officer for HealthWatch Reading. Just to share with you that one of the things that we have had is is feedback about not understanding the new way of working of the services. So I'm just trying to ask. The ask is, what communications has there been about the new way of working? Because I don't think the public understands. We do understand, but the public don't. So what methods have taken place to share all this information? Because I do think that if you share those kind of things, people will understand, who are the care coordinators, who are the social prescribers. They don't understand all that. So what has been put in place for them to understand all this?
Thank you. I think that's a really important point. So we've not met yet, Alice, have we? But I believe my team are meeting with you next week or in the next couple of weeks. So it would be really helpful to pick up some of these issues. To answer your question, so we have done quite a lot of work around explaining particularly new workforce in primary care. We've had various sort of over the last, I'd say, 3 to 4 years, we've done videos, we've had some public meetings and workshops with members of the public. And we have also, last year, that was a key element of our winter communications campaign, which a number of our practices contributed to, again, by sharing information, so some videos, etc., or interviews with people working in these new roles. But there's something about how we get that out more broadly as well, I think. So we will be planning this year's winter communications for primary care over the next couple of weeks, and I think the meeting with you will be helpful to pick some of that up. So yes, I think there's more we need to do, but I do feel that we have done some work in that regard. I think the other thing is the digital literacy project and the work that we're doing to facilitate and work with practices so they're able to help the patients get onto the NHS app, use the online booking and the online consultation systems and so forth.
Can I just add one more thing? In the sense that there are some surgeries in Wokingham, for example, they're looking at sharing with the public about self-care. Could we look into something like that as well? Because there is an element of the public need to look at that as well, because to support the in the NHS and the GPs.
Yeah, no, absolutely. That's probably the other key message. Last year we did quite a lot of work, I mean ongoing, but particularly focused around winter, also around the NHS 111 and the NHS app as well, and the self-care information that's available through the app and through the NHS website. So I imagine that will also be something that we want to reiterate this year as well. I think the role of pharmacies as well is really key. We've got, I think we've got in Berkshire West about 300 referrals a month going from practices to community pharmacies now, and that's something that we would want to build for some of the more minor illnesses.
Thank you.
Thank you for your question there, Alice. Thank you very much, Helen. Just a quick point from me. Just, is there anything that the board can do to support messaging around, the right service, like keeping people out of A&E and things like that?
Yes, absolutely. And I think when we talk about communications and the work we do, absolutely it needs to be a multi-agency approach and really working collectively to get those messages out, and some of the more targeted messages. I think you have obviously links into particular the groups that we would absolutely want to use, and I think we do, to be honest. But as we get a bit more into more sort of detailed planning for the coming weeks, I can bear that in mind and flag that as something that's important.
Thank you very much for that presentation. It was really useful. So thank you.
Thank you.
Thank you. Okay, so moving on now to agenda item. I think we're going back to agenda item 8. So, which is the fire service winter planning for vulnerable residents. Yeah, it's online and it's Gail Muirhead presenting. Hi there,
Thank you very
Gail.
much for having me. Shall I just share, or is anyone else going to share my slides? I'm happy to share if that's easier.
Yeah, if you're happy to share, that's
Yep,
fine. Thank you very much.
No worries. Okay, are you all able to see those?
Yeah, that's perfect. Thank you.
Fabulous. All right. Okay, so I'm Gail Muirhead, Prevention Manager at the Royal Berkshire Fire and Rescue Service, and I'm here to talk to you about our local safety plan, and in particular the fuel poverty crisis that's happening and the impact of that, and what we're doing to try and reduce the impact. So at the fire service, we do work on a local safety plan, and we have one that's specific for Reading Borough Council, which includes the demographics specifically for Reading and also maps local risks and plans in response to prevention and response activity. It also includes provision for emerging risks, which at the moment is the fuel poverty and the impact on potential risks in the home. It is available to download from the RBFRS website if anyone would like to have a look at that. So this winter, we're thinking that it may well be different risks in the community due to the increasing fuel poverty. As we all know, there's a lack of money and less money to spend on safety and also on heating and lighting, and it's likely that people are going to really struggle, and because of that their behaviours in the home may well change. So these are some examples of what's circulating on social media. People are coming up with creative ideas and suggestions on how people can heat and light their home, some of which are not very safe. So you can see there the candles on the cooker, and there's lots of videos circulating on TikTok and Facebook and things of those. Also suggesting that people light their house with candles to save money. And people are also finding different ways of heating their houses, such as using barbecues inside and things. And our key hope is that we can get messages out and visit people and see people to reduce the impact of this and make sure that this doesn't translate into additional house fires. So with regards to heating, the particular risks that we're looking at are chimney fires. So it's possible that people might decide to open up their chimneys. Perhaps they haven't used them for many years, and they might think now's the time, and they may not have all the safety advice that somebody's had a chimney for a long time. They may well not want to spend the money on a chimney sweep, etc. There's also a big increase in people looking at log burners, and it's just important that people know how to use them safely. The other risk potentially is carbon monoxide. So if people are using alternative ways of heating their houses, such as candles or indoor heating and etc., turning their cooker on for heating rather than for cooking, there is an increased risk of carbon monoxide poisoning. Additionally, people might not spend the money on kind of the normal safety things like servicing of boilers, which also increases the risk of house fires this winter. Potentially using electric heaters and just things to dry clothes, and just behaviours that people might not have been doing in previous years. And of course the risk of hypothermia if people aren't in warm homes. So given that people are likely to be using candles more to heat and light their houses, normally candle fires account for 3% of house fires, and we're just keen that doesn't go up and become more of an issue. So there is basic advice that we're trying to get out to everybody about not leaving candles unattended, putting them on a heat resistant surface, buying from a reputable source. And that candle that you see there is actually one of our members of staff's candles that they had in their own home. And luckily, a disaster was averted because they were quite close by and able to put it out. But it just shows that it can happen to anyone. So that candle there was one of the Christmas ones where you kind of have like an outer layer with bits and pieces in it and an inner layer, and it's actually been made unsafely with some plastic in it, which wasn't obvious until it burnt down a little bit and then it caught fire. And of course, if people are if they've got cognitive problems or physical problems, then they're less likely to be able to react to this sort of thing. So these are the people that we really want to get out and see, and just make sure that they are safe in their homes. Another key trend is electric blankets. I've just put there a typical headline that I'm sure you've all seen circulating in the news about using electric blankets to save on heating bills. And it's just really important that people understand how to use those safely. In particular, when people fold them up, it does damage the electric. So one concern is that people are going to get them out from the attic, maybe not have used them for years, and then start using them and they may potentially be unsafe. So we are doing things like electric blanket testing with trading standards, and also trying to get out those basic safety messages just to keep people safe. Another potential area is landlords, because their margins have been reduced quite significantly with the rises in mortgages, and also particularly for HMO landlords who are paying for the bills as well. And there is a concern that with maintenance costs rising, that they do continue to maintain the standards with, you know, fire doors, gas safety certificates and electrical safety. So our approach to these emerging risks is that we have got a winter planning in place, and also we're really keen to work with our partners, because keeping people safe, it takes all of us, and making every contact count is really important. So we really welcome people signposting to us, and additionally we will be signposting to other organisations when we identify people that need help. So we do offer free training for professionals working in the community. So we'd like as many people to come on that as possible, so we can talk to them about the hazards and how to refer to us. Also a comms plan, and we welcome other organisations sharing our comms, and that will help us to counteract the poor social media advice, and also give out really good advice and practices, and also increase our safe and well visits. So our safe and well visits are either undertaken by firefighters or our specialist technicians. They'll go in people's houses, look in the home, and give advice on a number of fire safety issues. If needed, they'll fit smoke detectors and other fire safety technology, such as fire retardant spray, fire retardant blankets, and things like that for people that are smoking. We will also signpost to other agencies if we feel that person needs help, and we do look at the wider sort of health and well-being when we're there, and we will also safeguard if needed be. And just to note that post-COVID, we have seen, probably like everyone has, an increase in complexity of people's needs post-COVID in the community. We are spending longer with a lot of our clients because of those increased needs, and also noted an increase in the number of people needing our services. So you'll get a copy of these slides emailed to you afterwards, I believe. So I've just put those links there for anybody who's interested in finding out more about our training and how to refer. So professionals can refer for a safe and well visit, but also people can refer themselves. You can also partner with us by following us on our various social media, and it'd be really helpful to share far and wide the messages over this winter. Thank you very much, and I'll take any questions.
Do we have any questions? No, I just like to say, it's a really, really useful report. It's very informative. And I think, currently, obviously we are heading towards winter and we're expecting quite a cold winter. So this is all, particularly important at the moment, the cost of living crisis that, undoubtedly we're going to face. And the report really clearly talks about the issues. You mentioned the candles, increased use in candles, which is obviously really worrying, and people not using their service in the boilers. And, I heard somebody was talking recently about concerns about people pulling down fences and burning them, so all sorts of concerns like that, concerns which are a real worry as people are, quite frankly, very cold in their homes with fuel poverty. Very interesting what you mentioned about the heated blankets, because I know there's a lot of campaigns to encourage people to use them at the moment. So obviously really important to make sure they're checked. Thank you for the link to the training. I shall certainly have a look at that myself. And really just as a board, what can we continue to do to support the invaluable work that you're doing? And I'm just interested about as an organisation, obviously a huge increase in your workload, and obviously you're equipped, but how as an organisation, it's obviously just to comment on the work you're doing and the increased pressures that you're facing, almost a change of direction, increased workload. But thank you very much for the report.
Thank you very much. Yeah, so it's just about the complexity where it's increased, where we've really noticed, but we do have capacity to take on more referrals. So we certainly want everybody to keep referring to us, and we really welcome as many referrals as possible, because the more people we see, the more people we keep safe.
Thank you, Gail. Dr. Jachersky here. I'm just wondering, how, you mentioned you've got capacity. Do you have officers that work sort of in just a pan Reading or pan Berkshire, and how much do you work with maybe primary care to target specific patients that you feel might benefit from your input? I can think of sort of frail elderly living alone might be the ones that could do with more support. And do we coordinate together to target those patients to then get your targeted input? Thank you.
Yeah, so as many times as I'm invited to team meetings, I will go to them. So we do try and access GPs, primary care trusts, whoever will have us, talk to them. And we do have lots of members of staff from health coming on our training. But I really welcome a conversation with you about how we can perhaps target people a bit better and share that information and get into those people that perhaps you know of that we don't know of. So that'd be really useful. Thank you.
Thank you.
I can't see any other questions, but thank you very much for that. A really informative report. So thank you very much.
Thank you.
Thank you. Now we're moving on now to agenda item 11. And that's the Berkshire West Unified Executive Update, which is Andy Jachersky presenting.
Yes, thank you, Chair. So I'm Dr. Andy Jachersky. I'm Vice Chair of the board, but I also attend the what was the Berkshire West ICP, which is no longer Unified Exec. That acronym will be dropped, as we talked about earlier in the meeting. So this is just a summary of some of the work that goes on in the Unified Exec in the last quarter. So the Unified Exec had as a number of priorities of work that were discussed and are kept under regular review. Under mental health, there was a big push to do multidisciplinary team targeting of patients with low-level mental health needs that might need extra intervention. That's already been done through a lot of the MDT working that's been spread across the primary care networks, and they're looking to see how they may extend the sort of work on mental health issues through the multidisciplinary team way of working. We've also heard earlier from Helen about the additional roles reimbursement scheme. We call them the R's staff, which is the extra staff that has come into primary care networks to work in a multidisciplinary workforce way of working. As was again mentioned earlier, there's fewer GPs, but there's more other staff working in primary care to support the way we work. So this has been a big push as part of the priorities to try and get as many of these posts in place using the funding that's available. There was this, the scheme is a 5-year scheme which ends in March 24. That was the sort of the primary care network timescale from 2019 to 24. We understand that the money won't just be pulled at the end of that time. so we won't be left with staff sort of floundering with no funding. So we are trying to maximise the number of posts we have in place, so that we can then secure their funding beyond 2024. As we know, from the pressures in primary care, these are crucial members of staff in our workforce to support the way of working that we have, both for on-the-day urgent work, but also for long-term condition management. And going on to long-term conditions, the other next priority was about heart failure. There was a piece of work done around the integrated heart failure service in Berkshire West, about earlier detection, diagnosis, improving management, and for those patients that unfortunately live with it as a long-term condition, looking at personalised care and how to help them manage their condition themselves through better self-education, also using digital technologies. So it's a sort of a project that encompasses all the aspects of how you manage a long-term condition. There's a big push nationally on cardiovascular disease. Heart failure comes under that because it's usually caused by high blood pressure, patients who've had heart attacks in the past. And one of the other things to try and target is patients getting stroke. So there's a big push on monitoring blood pressure, detecting people with atrial fibrillation, and just generally trying to proactively detect and treat earlier and prevent the more devastating problems like heart attacks or strokes going forward. There's information given to the board about emotional health and well-being in children and young people. There's a strategy that's being updated, that it's being more outcome focused rather than just looking at this is a bit too much of a challenge and what we're going to do about it, but actually targeting real solutions and updating the whole strategy to make it more pertinent to provide the services that we need. Under intermediate care review, this used to be called rehab and reablement. This is looking after patients sort of between community care, primary care and the hospital, trying to prevent patients to go into hospital. And there's a big review being done on how that's working, looking at the data, trying to see whether the service is working as efficient as it possibly can be. I won't talk about ICB development because that was already mentioned as one of the agenda items. Just to mention, there is a delivery group that does all the actual work underpinning all of these things that we've discussed, that then report to the unified exec, and the various program boards that do the work on all these areas that I've mentioned to report into delivery groups. The delivery group sort of coordinates all the work that's being done across the Berkshire West area. One of the other big things that's being started is a review of the community nursing service. It's been under great strain with increased workload, workforce issues, recruitment. It's a big challenge in the Berkshire West area. So there's going to be a review of currently what's being done, and trying to look how can it integrate better, both in terms of staffing and in the way it interfaces with the primary care and GPs. So a project manager was approved and the funding for that was approved so that we can scope that work. The GP representation, just to mention that primary care networks have been in place for some time, but with the changes with the ICB and at BOB level, GPs are being asked to represent primary care on more boards. So that was one of the things that was being discussed about how that was going to be supported, and it might be something, Chair, we will need to discuss going forward. In my new role, well, not new, I have multiple roles, unfortunately, but one of my roles with primary care networks is looking at, like we have the hospital and the community service represented or are invited to the board, whether we need to get primary care in the form of the PCNs now invited as another key stakeholder within our health system. We had a presentation about adult social care adult services changes, and I don't envy the councillors around this table and the challenges that you face, both in terms of funding and the operational challenges going forward, and there's some big changes coming in the coming year. So we had a bit of an update on that from our adult social service leads that sit on the unified executive. And just finally, something that's very pertinent to our health and wellbeing strategy is about physical activity. We had some experts come to talk to us about the importance of that and how it needs to be looked at and integrated in all the work that we do. And Unified Exec agreed that we need to support making sure that physical activity through the work of our Public Health Director and all the initiatives that are available across Berkshire West and in Reading are thought about in all the work that we do. So that's just a quick summary about what the Unified Exec, which could become the place-based partnership board possibly going forward, does. Thank you.
Brilliant. Thank you very much. Do we have any questions on that? Any comments? Nope. Okay. Thank you. Well, yeah, a lot of activity noted and mentioned in the report, and the United Exec plays a key role in putting all of this together. And let's hope this board establishes its place on the ICB. So thank you very much. Thank you very much. So we're happy to note that. Yeah. So moving on then. So it's the agenda item 12, which is a Better Care Fund plan and narrative, which is to be presented by Bev Nicholson.
Thank you. Is that loud enough? Can you hear me? I'm rather short, so I need to lean up. Thank you very much, Chair. Nikki, would you mind? Oh, you have presented it. Thank you very much. Okay, so I'm just going to give you a quick overview. I'm hoping that people have managed to read through the reports. Apologies, they are quite lengthy, but I'm going to try and give you a summary now. I'm not going to read everything on this slide presentation in detail, but happy for them to be shared after the meeting with everybody present. Thanks, Nikki. So the Reading Integration Board agreed their priorities in June 2022, and the Better Care Fund plan for 22-23 reflects those priorities. NHS England actually released the planning guidance later than expected. It was due in February and was released in mid-July. Not uncommon, and many of us are well aware of this cycle. During the development of the plan, we actually consulted with a number of different people, different groups, so the Integrated Care Board, Royal Berkshire Foundation Trust, Berkshire Health Foundation Trust, and Integration Board membership, which includes voluntary care sector partners and with our local authority, neighbouring local authority partners across Berkshire West. A draft version of our plan was submitted to NHS England to get some further feedback. The submission was noted at draft stage as being good, with a few areas of improvement, and we've subsequently addressed those in our final return. And I'm glad to say that we actually submitted ahead of the deadline of 26th of September, and we submitted on the 21st of September after receiving delegated sign-off following consultation between the chair of the Health and Wellbeing Board, Councillor McEwen, and Shona Douglas, who's the Executive Director of Adult Social Care. So thank you for that. Next slide, please. Thank you. So just to give you an overview of what our return consists of. So we have 3 documents that we had to submit. So there's a Better Care Fund plan, which is an Excel spreadsheet template, and that sets out the detail of who's responsible for the sign-off, the income and expenditure that we get through the Better Care Fund, and the metrics that have been set along with the rationale and our activities to achieve those metrics, as well as the 4 national conditions that are outlined in the Better Care Fund guidance. The Better Care Fund narrative we submit as well. So that narrative is much more detailed about how we've developed our plan, and how we plan to meet the objectives of the Better Care Fund. And then there's a capacity and demand plan template, which is new this year, The template was to give an overview of the demand on hospital discharge and intermediate care primarily. So, for instance, things like rapid reablement, rapid response, and our capacity to meet that demand. The capacity and demand template, because it's new, did not form part of the assurance process, but it was a mandatory requirement for submission. And the Better Care Fund metrics for 22-23 are outlined in this presentation, so I will go through those. Next slide, thanks, Nikki. And that's just a quick overview of the governance structure. Some of that you will have seen in other presentations, and as we go through the rearrangements of our integrated care system and our integrated care boards, and then how we report into those various boards and into the integrated care partnerships. Next slide, thank you, Nikki. So the Better Care Fund national conditions, which I mentioned earlier, there are 4 of those. So we have to ensure that we have a jointly agreed plan with our local health and social care commissioners, and that's signed off by the Health and Wellbeing Board. And as I mentioned earlier, we have a delegated authority approach to that because of the timelines of the Better Care Fund and where it comes into the system, as it were, and the reporting timelines for that. Then we have to ensure that we have the Nhs contribution for adult social care to be maintained in line with the uplift to Nhs minimum contribution, and the uplift for 22-23 was a 5.66% increase. And we also have to ensure that there's an investment in Nhs commissioned out of hospital services. So that includes discharge to assess and intermediate care. And in fact, most of our plan is continuing supporting services that are out of hospital commissioned. And then finally is implementing the Better Care Fund policy objectives of enabling people to stay well, safe and independent at home for longer, and providing the right care in the right place at the right time, which is fundamentally what the Better Care Fund is all about. The Better Care Fund plan and narrative provide confirmation of how these conditions have been met. So if you could move on to the next slide, thanks, Nikki. Now, I apologise for the writing on here, it's a little bit small, but it just gives a very high-level overview of the financial resourcing that we have. So the Better Care Fund is not insignificant, it's 15.9 million, it's quite a big chunk of funding. And that is split between Disabled Facilities Grant, which is ring-fenced for supporting people and development of so things like wet rooms or fitting, housing aids and needs to support people with a disability. We've got the minimum Nhs contribution, and we've got what's called the integrated Better Care Fund, which is we can choose locally how we spend that funding. Locally in Reading, we use that for reablement care. That's where we spend that money at the moment. And then we've got some extra funding that we've contributed that supports carers funding and carers respite, and an additional contribution from the ICB. In fact, there isn't an additional contribution from the ICB. And then the breakdown of that spend in terms of how we meet the national conditions for the out-of-hospital spend. So we've got the minimum required spend is 3.1 million, and actually the planned spend is 5.1, so we definitely meet that condition. And for adult social care services, the minimum spend required is 5.9 million, and planned spend is 6.5. And then the next slide, please, Nikki. Again, very small, but let's just concentrate on the table at the top. So, which unfortunately doesn't align quite well with the screen up there. But there are 4 metrics this year. Thank you. There are 4 main metrics this year. We did have 5 last year. The one that's been removed is length of stay in hospital for admissions, but we've been asked to continue monitoring that, which we will do. The targets this year are admission avoidance, and this is per 100,000 population, Some of you who may be keen on watching figures will have noticed that there is a distinct change from what was reported in 21-22 to what we have here for our performance of 21-22. And that's because the method of measuring admission avoidance changed. So it still measures chronic ambulatory conditions, so things like diabetes and asthma and heart disease and things like that can be managed if people look after themselves and have their regular health checks. So they're still measuring those numbers of people, but they've got a different methodology that's much more robust now, and that's why the numbers have changed. So it doesn't necessarily mean that it's worse performance. It just means that actually we've got a much more robust method of measuring. So we've had to backdate all of our performance targets accordingly. And we've based it on, so Q1 was based on the actual figures because we had those at the time of creating our plan. Unfortunately, Q1 figures were 21% up on last year. So trying to find a reduction for this year, which they call a stretch target, was nigh on impossible. So what we've agreed with them is that we will just have no change for the remaining quarters in the year. And we'll just take that hit in Q1 because often quarters 3 and 4 are worse in the year, and we've predicted a harsh winter this year, so it will be a challenge. Discharged normal pace of residence, we've always performed very well there, so we've maintained that. And residential nursing home admissions, we've stretched that for a reduction this year. And then finally, we've got effective reablement service, so the increase of people that are still at home 91 days after discharge from hospital. We've agreed a Berkshire West target for that at 85%, which again will be a stretch, but again, it's good to have that stretch there. So next slide, thank you, Nikki. So the services that are supported by the Better Care Fund, we've got 31 schemes in our plan, and there are 18 of those that are commissioned by Reading Borough Council and 13 that are commissioned by the Integrated Care Board, formerly the Berkshire West CCG. These schemes have been rolled over into this year, continuing on from 21-22, and are listed in the Better Care Fund plan at Appendix 2 under expenditure. And the aim of this is to help us deliver against the Better Care Fund metrics and the 4 national conditions. And one of the RBC schemes is a project fund that enables service providers, including the voluntary care sector, to bid for funds for projects that support the Reading Integration Board priorities, and these are also aligned with the wider Integrated Care Partnership and Integrated Care System objectives. So this is an area where we can introduce some new initiatives, which is really quite exciting. Okay, if you could move on to the next slide, that would be wonderful. So I think there's quite a lot of this already in the report. We've got some mitigating actions to address any risk of us not meeting the targets, and these are outlined in this summary and also in the main report. So if anybody has any questions about those, then please do feel free to raise them. And if we could just move to, I think it's slide 12, Nikki. That's it, lovely. So really just in conclusion, the Better Care Fund has in the main continued to support our commission services through Reading Borough Council and the Integrated Care Board. And the fund is introduced to enable collaboration and integration across health and social care. There's more detail in the Better Care Fund narrative in Appendix 1, and that provides supporting information for everything that we're trying to do to meet the plan and the targets for this year. So thank you very much. I'll take questions if anybody has any.
Thank you very much for that report. Andy's got a question. Thank you.
Yeah, thank you, Bev. Just the targets that you've stretched for. I think if I remember, we were quite good at not sending patients out into nursing homes. You've pushed the target even lower for this coming year. Is that partly because there aren't enough beds in the nursing homes in the area? How are we well stocked with what we think we need? Have we got the services in place to prevent those patients going to nursing homes, which you've set quite a stiff challenge, haven't you?
Thank you, Andy. Yes, I mean, there are some challenges around bed-based care and availability of that, and we have noticed an increase in the complexity of some of our cases. However, we do have a considerable uptake in the use of technology enhanced care, and quite a significant increase in that. I think it was around 180 last year. It's up at 450 something now in this year. So, and that's off the top of my head, but that's from what I remember from the figures that I've seen. So, and those kind of things really do help in terms of keeping people at home and preventing that, those admissions as a result of increased frailty. So there are a number of initiatives underway at the moment. I know that we've got some additional funding coming in to support us with that as well, in terms of winter pressures and that planning. But it's always a challenge because we're advised by NHS England that they will not accept a standstill position or a worse position. So we've got to push it somewhere, and we felt that that's the area in which we felt we could push it, and maybe still achieve that target. But thank you.
Melissa has a question. Yeah.
Thanks, Chair. Just to add to your point, Andy, so Reading always do well in this because we have a real strong ethos on home first, as you know. We've talked about that many times. But nevertheless, there is a requirement sometimes for people to go into residential settings. In terms of the investment in the community-based services, so we've been working really hard with our providers over the last few months to ensure their workforce challenges are addressed, and that's the biggest challenge. And at the moment, the capacity is levelled out, so that's good. So we're absolutely meeting the demand. And we're hoping then as we come into winter, that will continue. In terms of the bed-based care, the biggest challenge has been not on general beds, but on beds for those more complex patients. So what we're looking at going into the winter is supporting our providers to look at different models of how we potentially upskill or indeed add additional staff to enable them to cater for those more challenging patients, but within those settings. So we're looking at more creative options because I guess, the beds available are the beds, and there are beds available, but it's can they support those that are the most needy? So we need to think about how we staff them so they can.
So is that because the complexity might lead to needing specific nursing care with more complex and greater skill mix to look after them rather than carers using, as you mentioned, Bev, technology to try and support them with, and upskilling the current workforce in carers rather than sending them to a specialist residential care?
Yeah, absolutely. So I think it's about looking at what the current provision can do to enable them to upskill to support those more complex people, and technology plays a role in that, absolutely. But sometimes it's about the staffing ratio, sometimes it's about the setting. So just thinking more broadly about that.
Thank you. Any further questions? No. Okay. I was going to touch on the winter pressures, but that's obviously been covered. But really good to see the better care fund plan for the year, and great to see the continuation of the successful schemes. Thank you very much for your report. So we'll move on, if we're happy to note that report. Yeah. So moving on then to agenda item 13, which is the integration programme update. And again, that's a presentation from Bev.
Thank you. Sorry, you've got me 3 times on the trot. Okay, thank you for that. Nikki, if you wouldn't mind sharing that overview. Thank you very much. And just move it down a couple of slides actually, because the first one pretty much covers what we've just covered in the Better Care Fund plan. So this is our integration, Better Care Fund integration update, and it just covers our progress to date against those targets that I've just been talking about. So Q1 for our avoidable admissions has been met, which is great. And I talked about this earlier on about the change in the way that it's been measured, and the fact that these conditions include people with diabetes, asthma, epilepsy and high blood pressure, just as an example. So that's met, which is very positive. So I'm happy to take any questions if anybody has any about these, but I do intend to go through them fairly rapidly so that we don't get hung up talking about the Better Care Fund forever and a day. Thank you. So if you could move on to the next slide, Nikki, that would be great. So this one's discharged to usual place of residence. Again, we've met this target. In fact, we did better than average last year. So we feel that maintaining this it's not necessarily a massive challenge. We feel it's reasonable. We're going to achieve this one. But it's still pretty high. It's a really good standard that we're achieving here. And then there's just a little note there that the orange line indicates the national performance against this, and the blue line indicates our local performance last year. So there were some variations there, but actually overall at the end of the year we achieved 92%, and it was 92.6 I think in the last month. Thank you, Nikki. If you could move on to the next slide. So this is what you've just been talking about, Andy, so admission to residential nursing care. So the maximum target for this year, it is a stretch. It's 469 versus an admission rate of 507 in 2021-22, and this is per 100,000 population. We're off on a winning start because our first quarter target was based on actual information that we had to hand. So that's definitely a help. And we have, so that's why we can report that as being met. And we're hopeful that the other things that we have in train to support people staying at home well will also help us continue to achieve that target. If you could move to the next slide, Nikki. Thank you. This has always been our challenge, so effective reablement. So this one we didn't meet. We only missed it by 1%, rather frustratingly, but it's the 91-day target when people come out of hospital and they're referred into reablement and they're still at home. It's a snapshot at 91 days. But under the NHS England rules around this metric, we have to include anybody that had passed away in that 3-month period for whatever reason. And it invariably is that inclusion that means we don't meet the target. So there's been a reduction for 22-23 to 85%. So we're hoping that we're much more likely to reach it in that period. So the target for the March 22 cohort of people that were discharged was still under the 21-22 target of 87%, which is why we're reporting performance as not being met for this particular cohort. If you could move on to the next slide. Thanks, Nikki. So this is about local measures, and we're talking about length of wait for discharge. And this is really where, as a local authority, we can influence that, because once somebody is medically optimised for discharge, then their wait in terms of how quickly they're discharged is about how all the services wrap around that person to get them out as quickly as possible. And, it is of note that we've had some real successes here. We've reduced the length of wait on pathways 3, which is really complex, down from 32 days in April of this year, so in the first part of the quarter, down to 8.2 days in April. So that's quite a significant amount of work. And a lot of that is due to the good relationships we have with our providers, in that effective early discharge planning, and continuing that work with our care market to ensure the most appropriate care is provided based on need. But where you do have complex cases, it can be a real challenge. Next slide. Thanks, Nikki. So this is about the impact of our community reablement offer. So numbers accessing the service have been a real challenge. They're still low. We were looking at achieving a target of 1,200 per year. And at the moment, we've had an intake of 225 as at the end of Q1. Majority of referrals are made following discharge from hospital, but not all of these people have reablement potential. So, and also, you know, some people entering the service are sometimes not well enough to start reablement, and that can impact on the numbers, or in some cases they refuse reablement. There's some positives in here though. So we've got an average length of stay with the service of 3.1 weeks against a maximum of 6 weeks, and satisfaction rates remain high at 91%. We move on to the next slide. Thanks, Nikki. So the additional BCF funding that we get for the Accelerated Integration Better Care Fund, that's the IBCF. The target reflects here the impact of the IBCF funding investment in reablement services, and that supports people remaining at home independent. It's noted that there's been a slight reduction, only 17, but a reduction nonetheless, the number of care packages offered in Q1 compared to the same period in the last year. And we're seeing a higher level of complexity in this quarter with our hospital discharges, and therefore the needs cannot always be fully met through reablement and home care packages. And next slide, please, Nikki. I'm not going to read these in detail. Apologies, it is quite small. But you will have read these in multiple different places when we're talking about the Better Care Fund and the Integration Board. So we've got 4 main priorities that were agreed with the Integration Board this year that support us in delivering against our Better Care Fund plan. And within those 4 priorities, there are 9 key projects, 7 of which are new this year. And a number of people have spoken about digital literacy as well this year, and we're quite pleased that we've got a digital inclusion project in here, and we've got one of our local voluntary care sectors supporting us with that as well, which is looking really good. Some really good engagement there. If we could move on to the next slide. So this is a really good news story. I just had to put a star on that, I'm afraid. It's so our multidisciplinary teams project, which is continuing into this year from last year as a result of being really successful towards the end of the year. We did some analysis on the cohorts that had gone through this process within the previous 6 months, and these are the outcomes at month 3 and month 6 when we're measuring it. So you'll notice a significant decreases in the number of referrals, you know, acute admissions, rather A&E attendances, SCAS's South Coast Ambulance Service, and then 111 and GP attendances. So really significant decreases of acute admissions in these cohorts at month 6. So these were people that were frequent attenders, and you know, some really good outcomes here that, you know, we're hoping that will continue. There were 78 people whose cases were reviewed by an MDT between April and June 2022, and we'll be able to show the outcomes for those cohorts at 6-monthly intervals, so we should be able to give the next update at the January Health and Wellbeing Board. And I think that's the end of my presentation. Thank you very much, Councillor.
Thank you very much, Bev. That was really informative, really useful. So thank you very much. We note the contents and performance, and it's you know, good to see the trend of the year, and positive to see the targets were met. And obviously, you highlighted the areas which are clearly not met in the report. So thank you very much. Very informative. Do we have any questions? Okay, so thank you very much. Are we all happy to note the report? Yep. Thank you. Right, so the next, I think the final agenda item is the Health and Wellbeing Strategy Quarterly Implementation Plan, a narrative update report, which again is Bev presented.
Yes,
so thank you very much.
I'm presenting on behalf of Amanda, who's on leave at the moment. So
well, thank you.
Thank you, Nikki. Well, she not sent it to you? I thought she'd sent it to you. I've got some slides here. I was going to say I can join and share it myself if that would help. Lovely, thank you. Okay, if you can just go on to that's it. So this was the initial snapshot when the strategy was developed of Reading, and we've had some significant changes since then. So if you could go to the next slide, Nikki, this just gives us an update, particularly around population. So we've had an 11% population increase since those figures were shared. So our population now is 174,000 people in Reading. And we're the fourth most densely populated area in the southeast, 64 local authority areas, which is of real interest. Some very interesting figures on this slide. So, you know, happy for people to have a look at it and maybe look at how that aligns within their local areas. And then there's the next slide, just shows the wider determinants of health. You know, with the general socio-economic, cultural and environmental conditions on the outside there, and then all the factors that influence that, living and working conditions and social and community networks and so on, and individual lifestyle factors. And then this is the overview of the strategic priorities for the joint health and wellbeing plan across Berkshire West. So reducing the differences in health between different groups of people, supporting individuals at high risk of bad health outcomes, help children and families in early years, promote good mental health and wellbeing for all children and young people, and promote good mental health and wellbeing for all adults. So I'll just run you through a quick update on each of those strategies. So, so the priorities, priority one, the Reading Integration Board takes a lead in this work and is focusing on this through the Better Care Fund and through our voluntary care sector partners to collaborate on integration projects. The Berkshire West-wide Inequalities dashboard has been developed, and this is in the stage of data checking and testing. And once finalised, we expect to be able to get a full report for Reading around the end of October. And this will form the basis of a robust population health management approach. So really looking forward to that. Some really good data coming out. I've seen some of the early drafts, and for those that are data minded, it's quite exciting. And there's a range of services that we provide through our system partners to support people to stay healthy and well at home. And also, you know, just flagging here that, you know, there are some focus groups that we have within this plan. So those with learning difficulties, people that are homeless, and those living with dementia, and their carers. You can move on to the next slide. Thank you, Nikki. So for to support individuals that are at high risk of bad health outcomes, we're very much using connected care. So we're using that to identify those groups of people that are high risk. I mentioned the multidisciplinary team working earlier. That very much is a factor that supports us in delivery against this priority. There's also the Closing the Gap initiative. So contracts have been awarded, including carers advice and respite services and various voluntary care sector services that really support the wellbeing of our Reading residents, and in particular those at risk of poor health outcomes. And then we've got the Better Care Fund, which supports a range of mental and physical support services, including adaptations to homes through the Disabled Facilities Grant I mentioned when I was presenting the Better Care Fund report. Next slide. Thank you, Nikki. So priority 3, so the under 5s work stream of the One Reading Partnership is leading on the priority action plan for this, with representatives from the maternity service, health visiting, education, including SEND, and the voluntary care sector. The priority project areas are to increase the take-up of free 2-year-old entitlement, especially in disadvantaged communities. And they've relaunched a parent volunteer scheme to reach parents and families who have not accessed their entitlement. The Department for Education have also extended the entitlement to include families from Ukraine and asylum seekers, really positive, so that they will be added to the target groups across Reading. And there's a project to roll out trauma-informed practice to early years settings, and that continues with positive response and really good take-up. And then priority 4, so promoting good mental health and wellbeing for all children and young people. So the second mental health support team is live from September. The official launch was on the 14th of September, and these 2 teams offer interventions and training for mild to moderate needs in schools and across 2/3 of Reading. NHS England is continuing to roll out further waves of mental health support teams, and we hope to secure our 3rd team in the future as part of the Berkshire, Oxfordshire and Buckinghamshire's mental health provision. Primary mental health teamwork with children and young people with more complex mental health needs has reflected on the increasing complexity of need over the last year. They also support with training and support other professionals through consultations around mental health and wellbeing. There's a new jointly commissioned specialist child and adolescent mental health service for children and looked after children, and they're recruiting staff. We have a task and finish group in place to work with an assistant psychologist on developing culturally appropriate services. And information will work closely with local community groups and children with young people to develop that. And then partnership working continues with a focus on understanding the local mental health and wellbeing needs and the offer that's to make it sure it's consistent approach to mental health trauma informed work. And when working with schools through therapeutic thinking approach with a focus on neurodiversity and vulnerable populations. And then last but not least, promoting good mental health and wellbeing for all adults. So the task and finish group attached to the mental health, mental wellbeing group are launching at the end of September to focus specifically on developing culturally appropriate services, resources, and signposting, development of data collection and sharing across the system, and developing training and workforce programs. As partnership working continues to grow that development of the partnership and identify projects that can tackle specific conditions linking physical activity and mental health to training and workforce development. And then the first draft of the mental health needs assessment will be completed by, it says by early October. I presume that's at a later date because I haven't seen that yet. And piloting of the mental health referral resource for frontline workers will be completed by January 2023. And last but not least, procurement of services through the Closing the Gap funding has also resulted in further services supporting mental health and wellbeing for the community from the 1st of November alongside increased joint working. So thank you very much. There is a slide there for questions, but I would just say that this is not my presentation. So I may be able to answer some, but I can't guarantee that.
Thank you, Bev. Thank you very much for that. Really interesting and informative report. It's really good to see an update of the deliveries against the priorities. So thank you. Can't see from the report whether if everything's on track. Is there anything that you need to bring to our attention and the deliveries?
There is to be a launch of the Health and Wellbeing Board strategic action plans on the 26th of October.
Yeah.
And that's going to be here in the council chambers. So we'll be able to give a really good update then on how things are progressing against each of the plans. there's an awful lot of work that's been going on in this space, and actually there's a lot of crossover with what's already happening in this space, which is really nice to see. It's all beginning to link up. And the nice thing about this strategy is that it's that overarching umbrella across everything and brings it all together. So yeah, some really positive work that's going on, and that launch programme I think is going to be very well attended. In fact, I was speaking to somebody yesterday that's definitely coming because they want to do the networking and engage with us on what we're trying to deliver. So thank you.
Yeah, no, thank you very much. Do we have any other questions or comments? Nope. Okay, so thank you. If everybody's happy to note the report. Yep, thank you very much. Thank you, Bev.
Thank you.
Right, okay, so the following 3 items are just for information, and they will be, sorry, apologies, the following 2 items are just for information, so that's 15 and 16. So I understand they will be brought back in January.
So just to clarify, Chair, these reports were produced by Healthwatch with the previous provider, and the current provider, the advocacy people, have now taken over, and they're going to be bringing their future plans. Okay. No, they're going to be bringing their future plans for work to the January meeting. So these are things that were done before they took over. Okay. So they're not presenting these because they weren't involved in it, but they will be bringing their future plan to the next meeting.
Thank you. Thanks for that update, Nikki. Okay, so that's the unless we've got any. Oh, apologies. Thank you, Alice. Did you want to speak?
Oh, I was going to say that we will look into those what has been shared as well as part of our work plan as well. So it's not going to go away. The only thing that I would say is what the previous people did for the annual report. They didn't have any plans. So whatever we are planning will be very new. So we are planning to do a roadshow about our work plan in the new year.
Oh, thanks, Nhs. Thank you for that update. Okay, so that's it then. Is there any other business? No. Okay, well, that's thank you very much, and everybody. That's the end of the meeting. So thank you very much.